Yet. My name is Rich Bazzillo. I'm the Executive Director of the New England Hemophilia Association, and welcome to our second series in our Consumer Medical Symposium. For those that were with us last week, you heard Dr. Croto give a great presentation about emerging therapies. This week, we have a treat for you. We have four incredible providers from around New England who will be covering four different topics. The topics will include current therapies, establishing a healthy relationship with your provider, navigating emergency situations, and telehealth. Many of these topics were based upon survey results from last year and things that you have been saying over the course of the past year with our programs and services. As you heard last week, or if you're new this week, Consumer Med was formed 5 years ago, and this event usually rotates around locations throughout New England. It has been held in Portland, Maine, Portsmouth, New Hampshire, Southbridge, Massachusetts. It was virtual, and next year we are definitely hoping to go where the location was last year, which didn't happen, to Connecticut. There are three pillars part of this event. It's understanding current and emerging therapies, number one, the psychosocial implications of change, and number three, insurance. So over the course of this month-long event, you will be hearing those types of topics being addressed. So I want to introduce our panelists, and after I do that, I'm going to do some live polling. So if you don't have your phone nearby, please grab it. And if you've never done live polling before, don't worry, we will walk you through it. So our panelists tonight, and these will be in the order of which they will speak. We have Dr. Salley Pels, who is the director of the Rhode Island Hemostasis and Thrombosis Center, who will speak first about current therapies. Second on the agenda is Emily Bisson, the associate director of the Connecticut Children's Hemostasis and Thrombosis Center. She will be speaking about establishing and maintaining a healthy relationship with your healthcare providers. Number three tonight is Dr. Jeremy Madrid, Pediatric Director of the Hemostasis Center at Dartmouth Hitchcock. He will be speaking about navigating ER situations. And then last but not least, we have Shelia O'Donnell, who is a lifespan provider at the Maine Hemostasis and Thrombosis Center, who will be talking about telehealth. So a packed agenda tonight. You guys are all experts on Zoom. You know, you could turn your camera on, you could turn your camera off. This is being recorded tonight, and it will be posted on our YouTube channel. So without further ado, let's do some live polling because we're going to keep with the theme of St. Patty's Day. So let me pull up my screen and we will start the live polling here. All right. So the first question is, what is your favorite St. Patrick's Day tradition? So this could be anything, and we don't track who says what here, so it's completely anonymous. So what is your favorite St. Patrick's Day tradition? And yeah, eating, of course. Hopefully you're going to be eating some corned beef either tonight or this week. So we have a Southie parade, green beer, a boiled dinner, eating, of course, hitting the pubs with family. Oh, bonus points, whoever put the shamrock in there. I have no idea how to do that, but Newport Parade, I've been to that parade. It's awesome. A lot of corned beef. Awesome. Eating and taking pictures with Nana. Well, hopefully you could do that again next year there, or this year, maybe later on tonight. So this is a question. Let's test your knowledge. True or false? St. Patrick's Day was believed to have died on March 17th. True, text 1, false, text 2. So St. Patrick's Day was believed to have died on March 17th. So right now, for those on the phone, overwhelmingly, we have 92% with false and 8% say true at 13%. So I'll give it a couple more seconds here, but what is the significance on March 17th? Did St. Patrick die on this day? And the answer, you guys are correct, 88% was false. He was born on March 17th. All right, let's go on to the next question. What nationality was St. Patrick? Was it 1, Irish? Was it 2, German? Was it 3, Scottish? Or was it 4, British. So you can text 1 for Irish, 2 for German, 3 for Scottish, or 4 for British. So let's see, for those on the phone, this is always like the Kentucky Derby here. You can see who gets ahead, because just when you think the winner is, you have sneaking. So it was Irish all the way. Now it's about even. We have 26% Irish, 32% British, 21% German, and 21% Scottish. So the answer is Scottish. St. Patrick nationality was actually Scottish. So the more you know tonight, hashtag right there. All right, let's go on to the next question. How many pints of Guinness are consumed worldwide on St. Patrick's Day? This is on average. Is it 13 million, 1 million, 6 million, or 1 billion? And please do not drink this much Guinness tonight, because you're going to need more than a consumer med webinar if you're doing that. So 13 million, 1 million, 6 million, or 1 billion. All right, let's give it another second or so. And so for those on the phone, 57% say 13 million. That is correct. On average, 13 million pints of Guinness are consumed worldwide on St. Patrick's Day. I had to throw this one in here. Do you know the significance of March 19th, which is St. Joseph's Day? So the Irish celebrate St. Patrick's Day, and 2 days from now, actually 1 day, it's Friday, is March 19th, St. Joseph's Day. So 98% Italian American. I will wear green for St. Patrick's Day, but really St. Joseph's Day is a important holiday. I'll just give you a really brief overview of St. Joseph's Day. There was a famine in Sicily, and the crops were dying. They didn't know what to do, so they prayed to St. Joseph, who was from that area, the patron saint. And it rained, and they had a big feast at the end, and they ate these amazing, delicate pastries called zeppelas. So if you're in Rhode Island or in the North End, eating a zeppela and wearing red on Friday is a tradition. I have never gone on March 19th without wearing red and eating a zeppela or two for breakfast. So if you have an Italian bakery near you, go get a zeppela on March 19th. Okay, enough about food. We want to know about you. How are you connected with the bleeding disorder community? Text 1 if you have a bleeding disorder, text 2 if you're a caregiver, text 3 if you're a partner or a spouse, text 4 if you're a sibling, text 5 if you're a healthcare provider, and text 6 if you are other. So right now, it looks like I have a bleeding disorder is about 40%, followed by a caregiver, 31%, spouses are 3, siblings 6, healthcare providers 9, and then other is 13. All right, let's go. There's 2 more questions left. What is the greatest challenge you are currently facing managing care or treatment for your bleeding disorder? This is an open-ended. So what is the greatest challenge that you are currently, or your child or children are facing care or treatment for a bleeding disorder? And this could be anything here. Accessing new veins, paying for it. Let's see. Inhibitor concerns, none for now, knock on wood. That's great. Sticking to my regimen, new fear about infusing. SP needs hemo assistance, keeping on my prophy schedule, wanting more choices. Awesome. Great. Well, you can continue to put these into the chat as we go over venous access as I get older. All right, last question here before we turn it over to Dr. Pels. What are you hoping to take away from this panel discussion tonight? And this could be anything as well. You could text this to 781-412-7971. A better understanding. Great. Clarity. Awesome. And the question is, what are you hoping to take away from this presentation tonight? New insight. Well, good. All of these 3 categories right here will definitely be addressed. Updated education, something new regarding future treatments, tips from the New England Dream Team. I think all 4 of you are going to get t-shirts. I like this. The New England Dream Team is on tonight. Hope. Okay, well, without further ado, as you continue to put these in, you can put them in the chat. I'm going to stop sharing my screen and I'm going to spotlight Dr. Salley Pels. And let me just bring up my presentation as I do that. So one moment. All right, there we go. It's always tough when you have multiple things on your screen there. So you see the lovely faces on here of who you will be seeing tonight. And I'm just going to go through here really quick. A thank you to our committee. You all are incredible for what you've done. Thank you to our sponsors, Bayer, CSL, Genentech, Novo, Octapharma, Sigalong Therapeutics, Sparks, Takeda, and Unicure for being our presenting sponsors of this event. Our champion sponsors, BioMarin, Sanofi Genzyme, and Pfizer, and our advocate sponsors, Accredo, Biomatrix, CVS, Drugco, HFA, Paragon Healthcare, and Superior Biologics. Thank you for believing in NEHA as we continue this. Agenda, we'll go over this a little bit later. You know about the fanny pack, which we'll get into. And here is the first topic. And Dr. Pels, I'm going to now turn it over to you.
All right. Thank you so much, Rich. And I just want to thank NEHA for the invitation to be a part of today's panel. I have been asked to review current therapies, and I'm really going to focus in my presentation primarily on, hopefully, oh, we got this going. Oops. Yep, sorry about that. Just technical difficulties. So I'm going to focus on the current hemophilia prophylaxis strategies, things that you might want to consider when discussing these options with your hemophilia treatment center providers. And I'm really talking about what is currently available. I know that previously Dr. Croto had gone through and discussed the emerging therapies, but want to kind of focus in on what's available right now and the kinds of things you need to consider when it comes to the therapeutic options. I am starting out by using this graph, which I like to use in sort of framing sort of how these therapies might help someone achieve sort of normal blood coagulation or hemostasis. When we're thinking about it, or looking at this graph, the bottom line really represents the severe hemophilia state where patients are at risk for spontaneous bleeding events and are not very well covered, obviously. With this middle line here, this and above, it represents our mild hemophilia state where most of the time you're well protected from sudden spontaneous bleeding events, but you might still be prone to having bleeding, particularly with injury with surgeries. And of course, the top line is our normal hemostasis where you're covered from bleeding events, either with trauma or surgery, and where this is the various treatments are going to sort of put you in each of these ranges at any one particular time. So the first treatment product that I'll talk about are your standard factor products, your traditional factor therapies that replace the protein that's missing. These come in a variety of different flavors, particularly for patients with hemophilia A. There are several generations of recombinant products that have changed over the decades to where when they were first developed, they contained some human-derived proteins, but over time, those have been eliminated and they've made changes to make them safer and have the lowest potential for transmission of things like infections. The original factor products, of course, were plasma-derived, human-derived, where there was the potential for infections, but again, over time, those factor products have become safer as well. When it comes to the next factor product type, we have our extended half-life factors, which are longer lasting in the circulation in the body, and they allow for less frequent dosing to maintain a better profile as far as where you are in a hemostatic range. These products have been modified to add a different molecule or protein that really cuts back on the amount of processing and degradation that happens with the factor when it's after it is infused. So it means that the individual who's getting these factor products doesn't need to infuse quite as often and can be protected for longer. The last type of factor therapy, or the last type of therapeutic strategy that I'll talk about tonight is the non-factor therapies. Really, the only product on the market right now is emicizumab or Hemlibra. It's does the job of factor VIII, but is a completely different protein. It's made up of an antibody that helps to bring two of the other coagulation factors together and help to promote normal blood clotting. This medication is administered subcutaneously, meaning under the skin, as opposed to the traditional factor products that are administered IV. And this is an important distinction because it allows for an easier way of administering, and it comes into my next slide, which goes through some of the advantages and disadvantages of each of these products. So, when we compare these different treatment options, as I said, the standard half-life products have been used for many, many years. The biggest downside that most people speak to, or one of the big downsides that most people speak to, are the fact that it requires intravenous administration. This can be challenging, not only for parents of very young children trying to infuse and get a vein, or it obviously, as we saw on the poll, as we get older, our veins get challenging as well, and there are other concerns that arise with blowing veins and pain and other discomfort that comes with the infusion. But the pros of this therapy is that the standard of care for decades has been these therapies, where they're well studied, and we know how to use them and maintain a reasonable factor level and maintain and prevent recurrent bleeding episodes in our patients and ourselves, for those of you here. And the downsides, as I said, are intravenous administration. The therapies are not always sustained. They require regular dosing. And so for young persons or young children, older individuals who have venous access issues, sometimes we have to move to things like intravenous access devices, portacaths, that may require a surgery, which obviously has its own risks. These ports or venous access devices can be a risk for infection. They can also they can also have other complications, like a blood clot can develop in them. So those are all things to consider when thinking about having to infuse on a regular basis. Additionally, these factor products are prone to, as many of you know, the risk for inhibitor development. So an inhibitor is an antibody where your body makes an immune response and tries to destroy this foreign protein, and it makes these factor products useless, and so you need to move to other types of therapies, or attempt immune tolerance, which is high doses over a long period of time to try and suppress that reaction. In addition to our standard half-life products, as I said, we have extended half-life products. These have the great benefit of requiring fewer infusions. It's considered as an improvement on our standard of care. But the downsides are that it continues to require intravenous administration, and it still requires regular dosing. So some people may respond better than others. Certainly the factor VIII products tend to have a shorter half-life overall. The factor IX products can offer particularly the extended half-life products, can offer longer intervals between infusions, which can alleviate some of the burden when it comes to intravenous administration, but it still requires the IV access. And of course, it still lends itself, unfortunately, to the potential for inhibitor development. Now, these factor products, as I said, these are the standard, have been the standard of care for a very long time, but for many of you in the hemophilia A community, you've recently had the advantage or the development of this other product, which is our bispecific antibody, or Hemlibra, which is a non-factor product that does the job of our factor VIII. The benefit here is it's subcutaneously administered. It can be dosed anywhere from 1 to 4 weeks, and it works despite an inhibitor status. So regardless of the fact that you may have had an inhibitor to the factor VIII products, you can still infuse or receive this therapy and see a great benefit and in reduced bleeding events. Of course, for patients who are choosing to switch to something like a bispecific antibody, we do know that, as I showed before, the kind of protection it gives you, it really puts you into the mild hemophilia range, and it's not to be used for acute bleeding events or treatment, let's say in the setting of a major surgery. You still need to be able to use a factor product to minimize bleeding symptoms or protect yourself from significant bleeding with the surgeries. And so the downsides of this product are that it's only available for hemophilia A. So unfortunately, we don't have a subcutaneous non-factor product yet for hemophilia B. And the other main concern that certainly providers were also quite worried about when this initially came to market was that it does also interfere with lab testing. And so our ability to understand where is this patient in regards to their factor level and how that relates to how well we're doing with preventing bleeding or giving them the sort of normal hemostatic effects, we do know that interference with the lab testing makes it a little bit more challenging. That in and of itself makes makes patient and family education around this medication a lot more important, because a lot of other providers, not hemophilia providers, but emergency room physicians or primary care providers, are not as familiar with this medication and need to be educated that, even though it looks like my blood is clotting normally in the test tube in the lab, it might not be the case in my body. And if I'm bleeding, I still need factor. So that's a really big, important point that we try to drive home with patients and families is you still need factor for bleeds or injuries or surgeries. The other thing that certainly is important to know is that there is a potential blood clotting or thrombosis risk when it comes to this product. And it's particularly important to know that it's primarily for those who have inhibitors and are using a bypassing agent, specifically the FIBA bypassing agent. There were a few instances of thrombotic events in the initial trials. And so we do have to use caution, and we try not to use FIBA if at all possible if someone really needs a bypassing agent, meaning not your traditional factor products, but for those who have inhibitors who are using the bypassing agents, our preference would be for the recombinant factor 7A. All of this is, the baseline of information about each of these different products is important to take into consideration. But what I want to sort of also express is that every individual patient has specific needs, and there are certain things that are more valuable or a priority for you or for your child. And so any of the, the information I'm providing here is intended to really be a framework to to help you to think about the kinds of questions you want to ask your provider, the kinds of therapies you think might be best for you or your family member. But I want to also ask, to throw out some questions and answer them and simultaneously as far as, how to think about these products. So one of the first and foremost when it comes to treating your hemophilia is, is this therapy safe? All of these products have been documented to be safe. We know how to administer them safely and keep our patients safe. So I don't think that's a big question right now with our current therapies, but this is a very important question as we move forward with some of the emerging therapies as well. Additionally, is this therapy going to be easier to take or to give? As you know, the IV therapeutics are a little bit more challenging, and the subcutaneous medication is definitely easier, but are there other things that we need to consider? So how often am I going to be taking this therapy? The standard half-life factor products are going to be given more often. Extended half-life potentially fit less often, and certainly the non-factor therapies are given on the biggest interval. Will this therapy allow me to avoid spontaneous bleeding and also have an active lifestyle? That's very important. Obviously, the goal is to have an active, healthy life with as few bleeds as possible. But we're not all going to put ourselves in a bubble, and we want to make sure that you and your family members are protected if they're going to be out there, playing soccer or doing sports. And so, these therapies might be, one therapy might work better for one individual and another therapy might work better for another. And so it's important to talk to your providers about what your goals of care are, not only for, avoiding bleeds altogether, but really thinking about the how to keep yourself protected when you're most active. And then, does my body need factor for other reasons? There has been some studies that have looked at the role of factor VIII in long-term bone health, and that's something that if someone has factor VIII deficiency or hemophilia A and they're not getting regular infusions of factor, is that going to be something to think about long term? I think some of the data is out on that, but it's still something that is something to consider. And then, as I said, if you're going to be active or you're at higher risk for bleeding with certain activities or you're having a bleed, you're going to need factor. And so even if you're on a non-factor therapeutic, you're going to have that backup factor product there for those events. And then, will this therapy choice affect my ability to pursue other therapies in the future? This is a big important question, because for those who either have inhibitors or at high risk of inhibitors, if you're getting regular infusion of factor and you're suppressing an inhibitor or keeping something at bay, will switching to a non-factor product be the right choice? And if I want to do something like gene therapy, is that going to be available to me if I go on to a different product? And these are questions that we don't always have the answer to, but it's important to talk to your provider about and make sure that they know what your long-term goals are, and sort of think through the implications of some of these therapies as new therapeutics come out as well. I think I want to give my colleagues some time to also go present their piece. So I think that that's the end of my slide. I know that Rich might have a few questions for me.
Yeah, thank you, Dr. Pels. That was a great recap. I know it's not easy to capture all this information in a short amount of time, but awesome job there. I'm going to throw a couple of questions that came up in the chat at you, and then we'll transition into Emily. Has there been any issues identified when using a standard acting factor therapy for trauma breakthrough and a long acting factor therapy for prophy? Is there potential for a thrombotic event?
So using, so if I understand the question, so using a extended half-life product for prophylaxis, but then a standard half-life product for bleed events or surgeries.
Correct.
Is that right? So when we are dosing these, we certainly need to take into consideration the last dose of your standard product, or of your prophylaxis product, and where we anticipate an individual to be when they are, as far as their factor level, when they are having the bleeding event. However, we are certainly, going to advise that an individual call their HTC, make sure that they're giving the right dose, and certainly for the most part, we're not necessarily having patients give super high doses repeatedly without some contact with the HTC, so that we can make sure that you're getting the appropriate doses.
Awesome. Great. Thank you. A couple more. Is the rate of patients developing an inhibitor the same for standard half-life products versus extended half-life products?
So we haven't seen a lot of difference when it comes to the inhibitor development in these product types. There hasn't been a new large head-to-head study looking at all the different factor products. Obviously, a lot of people are potentially familiar with the CPNP trial, looking at the differences between the plasma-derived and the recombinant products. And so there doesn't appear in with the newest iterations of these other factor products to be any significant spike in inhibitor development. And so we're not as worried about that, but for any one individual who might have any, particular risk factors that are associated with inhibitor development, we are always monitoring and keeping a close eye on their progress and bleed events, and making sure to evaluate them for inhibitor if there's a concern.
Great, thank you. One more question, then we're going to save the rest for the whole panel at the end. If you had a history of a clot formation in the past, does that place you at higher risk on Hemlibra for this happening again?
I would say it depends on the situation in which the clot occurred. And so I wouldn't say that it's something that you are necessarily not able to get. It would really depend on the whole picture, and talking to your healthcare provider about that.
Fantastic answer. Thank you, Dr. Pels. Up next on the docket, spotlight is on Miss Emily Bisson, the Associate Director of the Connecticut Children's Hemostasis and Thrombosis Center. Emily, the floor is all yours.
Hello, everyone. Thank you to Rich and Sarah for having me, and I've had the privilege to work with all of the providers on the panel tonight, and I'm grateful to be asked to join you all. Hold on. I can't advance the slide.
I could do it.
Okay, I'm sorry.
No worries. Yeah, just say next slide and I'll do it.
So I've been asked to talk about collaborating with your treatment team, your HTC team. And I think overall, I know all the folks on this panel, and I really do think that all of my colleagues across New England really want to partner with patients and families in your journey of living with a bleeding disorder. And I would say communication is the foundation for strong partnerships. So sometimes we go long periods of time between contact with our patients, and I think we all always are thinking of you and hoping everything's okay, but really wanting to encourage folks to talk to your healthcare team about what's going on in your life, and as you move through different life stages and struggle with bleeds or get a new job or have other health concerns come up, because we especially with all the new therapies, we're really trying to individualize treatment plans, which means that we need to know you and your goals and your concerns and what you're doing in life in order to do that successfully. So please communicate with your team, because that will make for I think a much better relationship with your team. Next slide. So I mentioned communicating with the team. Please share what's working for you about your current therapy. What do you like? What doesn't work? Do you have a new job? Dr. Pels mentioned determining what a treatment regimen might be best for you, or whether it's time to consider a new treatment option based on whether you're playing sports or started a new fitness regimen. I know lots of us started some new activities during this quarantine period. And so are you moving around more? Are you moving around less? Are you moving physically to a new location? Did you get a new job? Are you leaving the city? Are you headed off to college or graduate school? Those all have implications on what we might recommend or ask you to think about before making a change in your treatment regimen. And keeping your HTC team in the loop. So we really want to be your primary source for bleeding disorder health information. This community has a wealth of knowledge, but this is also a really exciting time in the sense that there are so many new therapies, and people are switching to new medication or just changing up how they're using their current product to better meet and individualize their care needs. And so while we know there's a wealth of information in peers and in the community, we also know that everybody's health history and needs are unique and different. And so we really want you to come to us if you're struggling, if you have a bleed. We're figuring out how to use some of these new medications too, how to treat a bleed for patients using a non-factor replacement product. And we'd like to talk that through with you. We certainly don't want you to feel sort of like you're out there on your own trying to figure it out. New treatment regimens really do require new treatment strategies. It's not, treat early and often as it was for patients who are trying the non-factor therapies, or who may be on a clinical trial or considering gene therapy. So we have to sort of reshape what we have known about how to manage specific situations. And I think that's a challenge for us as providers, and it's certainly a challenge for patients and families who've lived with their bleeding disorder sometimes for decades and always handled something one way. And now we're asking you to think about it a little differently and check in with us so that we're all on the same page and you stay safe and healthy. And we want to collaborate with you to make those individualized recommendations. Next slide. And then I think those of you who had the privilege to attend last Wednesday's session with Dr. Croto heard that there's just so many new treatment options that are sort of on the horizon, in addition to all of the new ones that have come to market in the last even 5 years or so. It's overwhelming. We can't review them all with you at your appointment. I definitely go into visits sort of knowing a little bit about my patient and their lifestyle and trying to hit on a couple of key new developments that I feel like are relevant to them. But if you're interested in a specific new treatment option, please ask us. Sometimes I feel like I'm just running off a list and overwhelming folks, but I really do want to talk to you about the questions that you have, the things that you're interested in, and asking me a specific question or asking your HTC team a specific question about one of those treatment options and whether it might be right for you in the future, or just letting us know that you're thinking about it, is really helpful. So we encourage folks, if you didn't get a chance to listen to Dr. Croto's talk, it's on the NEHA website. It was recorded. It's great. If you listen to it, there was a ton of information that she shared. It can get overwhelming, even for those of us who speak this language and hear it on a daily basis. I thought it was an excellent talk. So if it felt like you got a fraction of it the first time, viewing it again is great. I know I intend to do that because I learned some great stuff from Dr. Croto as well. So attending programs like this and the NEHA's other educational offerings like Fall Fest are a great way to sort of keep up with what's new in the bleeding disorders community in an unbiased fashion, and a great way to get an overview and then follow up with specific questions with your healthcare team. And that's all I had. Thanks.
Awesome. Thank you, Emily. Great presentation.
Oh, I might have had one more slide. I can't remember.
Yes, you did.
I did. Sorry. Okay. This was just about how to reach your HTC team. And so I just want to remind folks, there's so many different ways to reach out, but we really do want you to call us for urgent matters. Please don't email or text or send a electronic health record request, a message, because we're worried that we won't get to you quickly enough. Save those important telephone numbers in your phone. Please call us about bleeds and injuries, especially if you've been treating something that's not getting better, or you end up in the emergency room with some sort of medical complication, or you might need surgery. The more notice we can have on those kind of things, and the sooner you tell us that the ankle bleed isn't getting better, the better, the more we can help you and sort of troubleshoot what's going on. Utilize your HTC's online patient portal. So I think many of us are on, or I would say all of the HTCs are using some sort of electronic health record. And they all have a secure patient portal that you can access, often on your cell phone. So you can send us that question that's not urgent, but that pops into your head at like 10 o'clock at night. You can just write us a little message and we will respond. And you can even send us pictures, which we always like. Sometimes that's a useful way if you've been tracking a bleed, or we've been asking you to document something. And then Sheila's going to talk later about telehealth options, but that's increased the convenience for many patients who might live a distance from the HTC or have work or school schedules that make that complicated. And then finally, oftentimes you'll get a call from one of our administrative folks or like our clinic nurse or HTC nurse before your big comprehensive annual visit. And that's a great time to let somebody know that, hey, I'm coming in and I want to talk about whatever new therapy or clinical trial that you heard about, because we can prepare and bring that information to you to the clinic visit, so we can come prepared to have that conversation. So if someone does call you and you talk to them on that preclinical appointment screening call, letting them know, or sending, if you miss the call or you just get the voicemail reminder, submitting it through the patient portal is great too. Okay, now I think I'm really done. I'm sorry.
Let's see. Yes. Well, as I said a couple of seconds ago, awesome job, Emily. It's so important for a patient to have a strong relationship with their provider. A question that came in, without getting into too many details of this question here, but what do you do when a provider may be pushing you to switch to a new product and you're not ready yet, but you feel pressured?
I think that acknowledging that, and I mean, we're human too. So if I were in that situation and I was, I had a patient who felt like I was really pushing them on something, I would want them to just say, hey, I'm just not ready to do this yet. I hear what you're saying. I know you're concerned about me. And then I think it's helpful if you can share what's going on, like why that feels like not the right fit, or you're just not quite ready. Do you need more information? Do you have a concern that we could help you address? Did you hear something or read something that maybe was a unique scenario that isn't necessarily relevant to your particular healthcare needs? Just trying to make sure we have the correct information. And then oftentimes I think as providers, when we want folks to switch products, it's because we feel like we're not helping you attain the best care for you. So I think just, being open and honest, we're really not trying to force people into doing things that make them uncomfortable. But I know sometimes change is hard. And so sometimes I need a nudge to do what I need to do. And so sometimes we're trying to just nudge you towards what we think will be better for you overall in terms of your healthcare and your goals.
Great answer, Emily. For those that have additional questions, we're going to wait till the end so we can move on with the panel. So with that said, up next, we have Dr. Jerry Madrid, Pediatric Director of the Hemostasis Center at Dartmouth Hitchcock Medical Center. So Dr. Madrid, I'm going to turn it over to you.
Perfect. Can you hear me okay?
Yes.
Wonderful. Well, this is very exciting. I see some friendly faces, and unfortunately, with the times, we're missing out on, the human interaction, but I definitely look forward to seeing some of you in our upcoming comp clinic here in New Hampshire. But thank you to NEHA and of course, the rest of the panel who I've learned everything from you guys. So that's pretty cool that we're doing this together. But just in terms of timing, one of the points that we wanted to discuss was, navigating the emergency room clinic in terms of bleeding. And I think this is important just in terms of, recently with the different products that we have and being able to keep the kids at home more frequently and not needing, the frequent emergency room visits is, a nice perk in terms of how far we've come along in, the treatment of hemophilia. But I do think sometimes there's confusions in, when someone needs to be seen in the emergency room versus clinic. I did put COVID-19. This will be something that will be discussed later, but I know with the times, something that's on everyone's mind. And then just addressing social media, online support, the different options that we have for that. So I think in terms of bleeding, the different things that we discuss in the clinic visits are the types of bleeding that require prompt emergency room or prompt visits. That being said, and I think this has been hit on by most of the group, is we're never bothered. If there's a concern for a bleed, that is part of my job as a provider to help navigate that. The things that keep me up at night is when I feel like I get a call from a family that says they were not able to sleep because they didn't know which route to take, and then we're dealing with a more emergent situation. But in general, the big things that have probably been reiterated from your providers are the head and spinal cord bleeds, so any type of trauma. If there's any bleeding that could be oral specifically, like the throat, the tongue, the things that can cause prolonged bleeding, especially in the time where different medications like Amicar can be very difficult to get. For other non-hemophilia bleeding that if they're not using factor can be a big issue. And then of course things like GI bleedings. I'm sure most of the families on here have heard us talk ad nauseum about psoas bleeds or any big muscles. that, are concerning for us, and anything with like eye bleeds or deep lacerations. I would say in general, those are the bleeds that when in doubt, should be evaluated. That being said, I would reiterate what Emily had just mentioned. We give you our numbers to definitely call us, because not only is it important to do that, but we can help in terms of reminder. Is there a cool pack or an ice pack that may be able to be given? The other part of this is what factor you have in supply, so that if you are going to the emergency room or clinic, you're able to take that and remember to take that, which sometimes, as in tuned as I would say most of our families are, in times of emergencies, sometimes we're just trying to go through motions and we can forget the little things. The other big part of this is when we get a call and we have a concern, we're able to contact the emergency room, because as much as we trust our colleagues in terms of dealing with emergency medical situations, bleeding disorders can be scary for providers who don't typically do this on a daily basis. And so part of it is, hearing from the hematologist, what is going on and what's the plan. And then I would say the final part of that is being an advocate. And I know the families that, see me here in New Hampshire, we talk about it, be the advocate. If there's something that doesn't feel right, speak up. And then if all else, call me, or, call our nurse, because we want to make sure that all of the things are being done, because we want an efficient visit, but more importantly, we want your child to be safe. So if it's a concern that's trauma, 911, those types of things, but call your hemostasis center. And so I can't stress more keeping our numbers in your phones. And now most of the kids, surprisingly, gosh, I can't even remember. I think I got my phone when I was 24 years old, but now that is not the case, and kids have phones quite young. So putting in the numbers and actually taking the time to put some of that medical emergency information in your iPhones or Androids, God forbid something happened that you are not able to speak for yourself, or for whatever reason your family find yourself separated, that information can be helpful in terms of like bracelets, necklace, and now iPhones. One of the things that I do think is important, and we talk about quite a bit in clinic, is the infusion log. I would say in terms of emergency room, probably not the most important, but if you're coming into a clinic, it is helpful for us. And exactly like Emily had mentioned earlier, if this is a bleed that you've been treating for a couple of days, not getting better, we can really, take that information if we need to give more factor or, increase the intervention for whatever reason. All of that information becomes important. I like to not bring up, issues with insurance, but that is something that we have to face, as providers, and to, make sure we get what we need for, the children that we're caring for, as much information as possible. So, I do encourage that. The bleeding emergency letter is definitely something that I've carried over from, my experience and learning from Dr. Salley Pels, and the importance of this letter, and really keeping an updated letter, just in terms of, again, sometimes when we're faced with emergency situations or concerns, I think things can, we can, miss things or not quite understand, what exactly is going on. And so having that letter is just another basis. And so, recommend, make copies of it, keep it in the bag that you would be taking with you to the emergency room. Of course, again, and, stressing a lot, call us, because, we can definitely go through that with a provider. But again, I think in situations where, we talk about giving factor first before imaging, those types of things are what's included in the letter. And so I think when it's in writing, less likely that you get pushback as parents, which I think when you're faced with an emergent situation can be overwhelming and scary, that the last thing you want to do is feel like you're fighting with a medical provider, which is never our goal. In terms of the different types of bleeding disorders, again, I think when in doubt, if you find yourself in an emergency situation, just mentioning that your child has a bleeding disorder is going to catch most providers, attention. And so with that, again, having a way to contact your team so that we can go over those informations. Dr. Pels talked about, the basic treatments and prophylaxis guidelines. And again, we reference these things, but in terms of, different situations and different bleeds, those things may change in terms of dosing, aside from your prophylaxis, or, again, more recently with those who are on emicizumab or Hemlibra, requiring additional factor, which I think can be confusing for other providers who, don't deal with this on a daily basis. I think the biggest things for COVID-19 is, are individuals with blood bleeding disorders at higher risk? I would say not necessarily, but with the community at whole, we're learning about COVID-19 on a daily basis and things are rapidly evolving. The ones that we do get concerned about, as with anyone, is, those that are, have inhibitors and are on some type of immunosuppressant or whatnot, which would be susceptible to, any type of viral disease. But I think in terms of, the, precautions would be, the universal precautions that, we share as a community. What extra precautions would be is really kind of state dependent, and I think depending on what the outbreak situation is. So, we touch base with your providers, your primary care doctors, and, really kind of follow the state guidelines. And I think for, us as a hemostasis center has been our, recommendations for families, just in terms of keeping families safe. It seems like one of the things that has come up is the use of social media, and I totally understand. I think especially, we're clearly all on Zoom currently, and, using things to give outreach to people, and using things like Facebook, Instagram, Twitter, gosh, there's probably more that I have no idea about, and I'm okay with that. And I think this is where the problem comes up is, sometimes using these resources, and putting things in terms of treatment or giving things, we as providers are not typically in tune to always looking at the different modalities, or we also are not connected with everyone that, we may be treating. And so, again, if you're posting, information or getting advice, remember that these treatments can be very, directed individually. And so one person's treatment may not be what someone else's treatment is. But again, I think having that discussion with your provider is paramount, and also not expecting that, as much as, we follow your families and children's in terms of their bleeding disorders, I may not be aware that, they have a bleeding disorder unless you specifically call me. And so again, I think this reiterates, there are so many ways to communicate these days, but, the best way is if there's a concern, definitely reach out to us, so that we can, really make sure that, we're helping to guide you in the right direction. I think in terms of time, I probably will go with, if we have any specific questions, and then hand over to Shelia, just so that we can make time for the rest of everyone's questions, which we really appreciate.
Dr. Madrid, thank you so much for that great presentation. A question that did come in is, I'm going to paraphrase here. I see a lot of patients diagnosing other patients in these support groups, bruises, bleeds. They're on extended half-life, they're on Hemlibra and what to do. As a new parent, how do I navigate what my medical team is giving me for advice and what a community group is giving me for advice?
That's a really great question. And I think can be really difficult, because I think we're all searching for support. And, I would say the important thing is, in terms of, the discussions, which obviously can be varied per individual, and then outreach to communities, I can only imagine what's online. And so I think, reaching out to hear what other, are going through, but also making sure that those questions are really clarified with your provider. One of the best things, and usually, I will tell my, patients or families, is, the best thing about pediatrics is being collegial. And I have no problems reaching out to a colleague in terms of, essentially a second opinion, if that's what's helping to just make sure that, of course, we want the best for our children. Situations like this with NEHA, having this outreach is, something that, I think we find really important and, really advantageous for our families to not feel isolated and, truly understand that, within the bleeding disorder community, there is variability. And so I, would never tell a family to not appreciate the input they're receiving from a community group, because I think it helps us as humans feel like we're not alone and there are others that are dealing with situations. But, also stress the importance that if you feel like there's a disconnect between your medical provider and information that you're receiving, I'm more than happy to reach out. And I would say most of the colleagues I work with, we really just want to make sure that you have an understanding, because the better you understand, the more likely that you're able to, keep yourself safe and probably follow, the recommendations that we would give.
Great answer. So hopefully that answered the question. I'm sure we could have a whole session just about that, which is so important there. So thank you, Dr. Madrid. If you have additional questions, please put them in the chat. But without further ado, we are now going to turn it over to, of course, last but not least, Shelia O'Donnell, who is the lifespan provider at the Maine Hemostasis and Thrombosis Center, who's going to be talking all about telehealth. Shelia, floor is all yours.
Thank you, Rich. And thank you, Rich, Sarah, NEHA, for inviting me tonight. It's wonderful also to be working alongside my colleagues again on this panel. Missed all of you dearly. Also great to see the patients again. Mostly we miss you the most, especially our patients from out of state, or our families from out of state that maybe aren't our patients, so I don't see in clinic, but normally see you at these outreach programs. So really nice to be in touch with you again. I can't wait to see you in person soon. So speaking of lack of in-person, that's a perfect segue into telehealth. A year ago this month, we were all thrust into the COVID crisis and wondering how it was going to be that we were going to accomplish all the things that the other speakers spoke about tonight with our patients. How are we going to have these conversations with our patients about product changes, product safety, product choice, about maintaining the patient-provider relationship, about the discussions about the emergency visits and how to best manage these traumas. And we very quickly landed on, well, initially we started with some nursing telephone calls and trying to do a telephone visit. And then we were able, thankfully, to transition into the Zoom telemedicine process. And it's really, for us, worked out beautifully. We've been doing it since basically early last summer and continue to do that to this day. We've been able to bring our comprehensive clinics online, which includes all the disciplines that all of our patients have always seen: their provider, their specialty nursing, social work, research. And even in our girls and women's clinics, we've been able to get our gynecologist, who works across town, linked in, working with us in those clinics as well. So it's really been a seamless process, and one that we couldn't be more pleased with as the best alternative we have for in-person. Ultimately, an in-person visit is the absolute way that we would rather go. There is no replacement for the face-to-face for all the reasons we've already discussed. And when it comes to bleed triaging, it can be really challenging to be trying to do this over the phone or via computer. It's possible, but that ideally would be best done in person. I suspect going forward that we will come to a blended process of some telehealth and some in-person visits. That being said, Maine has a lot of very remote areas in the state. And we've had a lot of feedback from a lot of our patients that they love it, that they don't have to spend a full day driving 2 to 3 hours one way to come in for a visit, and we can get it all accomplished with them via telehealth. The opposite of that is Maine being a remote state, we can have some technological challenges with the internet. I have to say, it hasn't been as big of an obstacle as I suspected it might be. Overall, things have gone quite well in that arena. We do have a few patients that have been challenged by the process. We do have some that are refusing to do a telehealth and they're waiting for the in-person visit. So I suspect going forward, when we emerge from this COVID crisis, and we will, that we're going to have a blended model going forward. And one of the unintended consequences in this process, which has turned out beautifully, is that with telehealth, we have more flexibility because we are not held to clinic space, clinic times. We can be more flexible with our patients because clinics always open Monday through Friday from 8 to 4:30. So we've been able to accommodate people that maybe have work or school conflicts that can't make it to a regular clinic day. So it might not be a comprehensive clinic per se, but myself or one of the other providers and one of our specialty nurses can see the patient on an off day and then have the ancillary services touch base with them after clinic. I wish we had more time, and I wish I had submitted a question to Rich's poll earlier. I would love to have heard from the patients, and feel free to send your comments or questions. I would have loved to have heard from the patients that have done telehealth, how they felt that it went. Did they feel like it met their needs adequately? Did they feel like there were things that weren't served well in telehealth, so that we can help improve that process? And basically, as far as the actual process goes in our center, we make the appointment, our admin makes the appointment, then you get a call that morning to make sure the internet connection is acceptable and that we're going to be able to make the visit. And then our nurses call you about 15 minutes before the actual visit begins, get through the questions, and then one by one, we come in and out of the waiting room to meet with our patients. So hope to see you soon, whether it be on telehealth or hopefully in person. But love to hear your feedback on how you feel like this process is working for you.
Great. Thank you so much, Sheila. A couple of questions that came in. How are you finding insurance is paying for telehealth? And are you hearing that going forward, this won't be a barrier for patients, that they're going to be forced to have to drive, especially in Maine, rural places? Do you think that this will continue and insurance companies will allow patients to access providers like at an HTC virtually?
To be honest with you, I'm completely involved in the clinical end and not in the billing end of the process. I could certainly send that information back your way, Rich. I'm not aware of any pushback from the insurance companies. I know telehealth versus an in-person visit is billed a little differently. But from my standpoint, I haven't heard any patients giving us feedback that, we've heard a lot of feedback about product coverage and lack of coverage from the insurance companies, but not hearing any negative feedback about the telehealth financial concerns.
That's great to hear.
Sorry, and you asked, will it continue to go forward? My guess is yes, because of the remote nature of our state, more of a blended model.
Perfect. Another question that came in about telehealth is this patient had a telehealth visit and they said it was a little awkward. Is there any tips that you can give when you have a child under the age of 18, so a teenager, and mom or dad are sitting with them? And how do you process through the computer screen versus it's very different versus being in person? Any tips and tricks that you found as a provider of how to make the screen atmosphere a little bit more personable?
I wish I knew a little bit more about what awkward meant, meaning that perhaps in an in-person visit, we can ask mom or dad to leave the room, whereas on a telehealth, they're all sitting together on the couch traditionally. I think that's, if that question came from a younger person, I completely understand that concern. And I think that's a really great point and something that we should consider going forward, because that is a valid concern. We haven't had a lot of one-on-one with our teenagers because of that. But I don't see any reason why we couldn't come up with a process, even if it meant that the teenager takes the phone and goes out in the car and sits privately for a little while, something a little more direct. What we do, and I don't know if this person was on a Maine telehealth visit or in another site, what we do is we don't have everybody, all of our providers on the screen at the same time, because that would be extremely intimidating for a patient to come in and be seeing a healthcare team of 5 people staring back at them. So we try to come in one at a time, and we try to tell people at the beginning, this is how the process is going to work today. But at the end of the day, it's Zoom, and it's not the same as an in-person visit. But I think we welcome your feedback and would do whatever we can to make it as comfortable as possible.
Thank you. This is the last question about telehealth. Then I know we're past 8, but this is such a good discussion. I mean, I can grab dinner and just keep going here because there's so much knowledge and experience. This is about a specific experience, but maybe you can give some advice. So, and there was a comment in the chat as well about you still have to go for blood work for the telehealth visit. And sometimes, depending on the HTC, they want a baseline factor level. Should the patient always call before blood work to say when they last infused if the provider is not giving them any guidance? So the question is, I infused 10 minutes before and then I got blood work done and it threw off the data. It's because my provider didn't tell me that I should have waited 12 hours, 24 hours. I'm on it every other day, 3 times a week. So I guess how can a patient take a more proactive approach if it is telehealth or in person about levels to get that accurate number? Or is it not as important to get that accurate number?
Well, that's a great question. And I think it goes both ways. If it's a hemophilia patient, we're checking factor and it's a WAPS study or a WAPS graph, a WAPS PK study, where they can accommodate for your prior dosing. What you need to do is communicate with us and tell us exactly what you took and when you took it, so we can provide that information to WAPS. If everybody's hopefully familiar with the WAPS studies, the patients, instead of doing a multitude of lab draws to check your PK study on a certain medication, we only need to do up to maybe 2. And then we can get a pretty good, it's a computer generated graph based on the general population and it shows how people respond to these different medications at these doses at your weight and height and BMI. So when it comes to a WAPS, it's not so important as long as we know what you took, when you took it. But if there's a provider looking for a baseline level, we absolutely want you to be washed out per se. So I would say contact your HTC ahead of time, because different, like Dr. Pels talked about earlier, the short acting products are going to wash out of your system a lot faster than the extended half-life products. So let us know that you're intending to go in to have your trough drawn. And it goes back to what Emily said, call us and work with us.
Great.
Dr. Madrid said this as well. We want to work with you. We want to help you. We don't expect you to be the doctor or the nurse practitioner out there figuring out how to treat yourself. Call us, call us, call us. We'll look at your product. We'll let you know when it'll be washed out, and we'll let you know exactly what would the best time to be to get your blood drawn.
Fantastic. Awesome. Thank you very much, Sheila, for that insight and all the great things you're doing and your colleagues at Maine Med. So that said, we're going to turn over to the entire panel. I'll probably go for another couple of minutes here addressing some additional questions. A question that has come up in the submitted and also online through a private is about stymate. If one of the panelists can address what is going on with stymate and when do you expect patients with VWD or other types of bleeding disorders to maybe get it? Is it a major red flag? Just kind of a conversation around that. So I'll turn it over to anyone who wants to jump in first there.
So I guess I could take it. So as many of you may know, stymate, which is the intranasal DDAVP or desmopressin, which is used for mild hemophilia or von Willebrand's typically, it was recalled nationwide several months or over the summer, I believe. And unfortunately, the company that was making it has said that they are no longer going to be able to make it for some time, and we are kind of left with, very few options when it comes to DDAVP. So there is an IV formulation of DDAVP, which we often use in the hospital setting prior to surgery. Or in our clinic. Sometimes some of us do our challenges with the IV form of DDAVP. And so we have that to fall back on, but we're not routinely sending patients home with DDAVP to be administered intravenously. Many patients with these conditions also use Amicar or aminocaproic acid or other antifibrinolytics, tranexamic acid being another one, which is fantastic for mucosal bleeding, and sometimes it's used in place of, especially now, in place of the DDAVP for certain bleeding symptoms. I think many of us are investigating alternative sites for production of intranasal DDAVP, but none of us have been able to achieve that yet. And so we are still working on that. I think more to come, hopefully, in the coming months with how to manage that.
Great, thank you, Dr. Pels. Would others like to weigh in on that, or we can go on to the next question?
Sally,
I think for the population that are using, I just wanted to reiterate that, this is something that, of course, we know is a big part of what has kept kids safe at home and having these medications to fall back on. So as soon as we hear anything, I can't stress, that enough, that, we would definitely be in contact with you and your family. If, whether it be that's, the stymate is available versus is there some other route that we would be going, and this kind of falls back into that bleeding plan, and so making sure that you have that follow-up with your provider to talk about, the different options that may be available. But we're all hopeful that, we're able to, figure out what, what is best to, maintain the status quo that we've achieved in the recent, past years.
Thank you. I am going to put in the comment chat here the CSL Behring Med Affairs number, that if you have questions as well, contacting the manufacturer directly can provide additional information. So that number was posted in the chat as well. Sticking with VWD, another question that was submitted is, with the new information that came out for VWD testing, has anything changed on the research and therapy side of things at all?
So I would say the guidelines are really helpful. There were new von Willebrand disease testing and evaluation guidelines that were released. There were not significant changes to treatment recommendations as part of those guidelines. And in terms of sort of research questions to be considered, I don't know if it drove new questions per se. I think that there are many unanswered questions, especially in some of the von Willebrand factor level versus bleeding symptoms. So we call that bleeding genotype versus phenotype piece. I think those questions are still out there, and there's efforts, including a Athens study looking at von Willebrand disease. Athens is the American Thrombosis and Hemostasis Research Network that all of your HTCs participate in. So there are efforts to collect more data to guide von Willebrand treatment. And Dr. Croto talked about a couple of new therapies on the horizon that may be useful for folks with specific subtypes of von Willebrand disease, some of the type 2 subtypes, some of the type 3 von Willebrand patients who might benefit from a couple of the products that are in the pipeline, but I'm not aware of any specific changes to current treatment.
I'll just add on to what Emily said and say that I think that the updated guidance also it supports a lot of what we're doing already, and it did speak a little bit more to considering prophylactic therapeutic options for those who are more affected with their bleeding symptoms, and so it's not as I said, it's not significantly changing what we're doing for our patients right now, but it's supporting our what we're doing, and as Emily said, we are continuing to try to enhance our understanding of von Willebrand disease and how it affects our patients, and how the different subtypes can be best managed. So.
Fantastic.
And I think that that's the, gosh, I'm hesitant to use the word fun because I'm not sure it's fun, but it's the variability between the bleeding disorders. And again, you can have a similar diagnosis, but the presentation or bleeding symptoms that someone have can, vary from very mild to severe. And again, it could still fall within the same realm of, the same diagnosis. So again, I would echo that, the recommendations for diagnosing, although it may be, a similar diagnosis to someone else, your bleeding pattern may be different enough that, our recommendation would be something completely different, so that, again, the whole goal here is really to just have, to let, these individuals live life and, to do the things that, are the driving force to keep you going on a daily basis. And so it may vary from, a home medication that you keep and, update every 6 months or however until it expires, or, some type of discussion with prophylaxis. And so again, really being able to discuss and follow up with your bleeding history is quite important, whether it be hemophilia or von Willebrand's or some other type of platelet disorder. That's the difficult part of hematology, is it's varied.
And that's actually a perfect segue, Dr. Madrid, of another question that came in. And Dr. Croto touched upon it last week, but there's some here listening tonight that don't have hemophilia or VWD. They have a platelet dysfunction disorder, or they have a factor 13, factor 1. Could some of these treatments that are being developed, whether it's gene therapy or a sub-Q injection, maybe one day be used for these super ultra rare disorders? And if not, could there be things that are being learned in 2021 about these new treatments that could maybe give some of these patients more of an option, because they have one option now, or maybe two options, or maybe no option? So that's a kind of a summary of a couple of questions that came in.
Yeah, I think that's a great point. And, I would say as a provider, part of this is, working collaboratively to, again, achieve, if you're having a bleeding symptom, to have bleeding cessation or risk for bleeding. So I would say in general, the answer to that question is yes. Could there be, off-label uses for the different type of medication? We find that that's a pretty common theme in medicine, especially when we're dealing with children. Of course, there has to be enough proof of why we're choosing to do some intervention, to really reach that goal of, prophylaxis or bleeding cessation. So it's very possible. And I think that, that will be interesting to see in terms of, patients that have relied on certain medications such as stymate, in particular, some of the, platelet disorder, what am I doing to help keep them safe? Especially if they're having acute bleeding symptoms. And it's, we're learning certain things are working better than others. And again, I think is, being very clear with the, the patients and the parents of, that there's no clear indication for this. This is what we're trying to achieve, and these are the risk benefits, but it's always that pendulum of risk benefit and, again, trying to achieve, what's going to be safest for, each individual. But I do think that we'll probably start seeing some, different case reports from institutions of different drugs off-label. And, it'll be really interesting to see how stuff like emicizumab, how it's gone from just even, hemophilia with inhibitors to, severe hemophiliacs. And then, the question of is, are there others who may benefit from it as well? I think we'll continue to see that process.
Fantastic. Thank you, Dr. Madrid. Any others like to weigh in on that?
No, I think I think I've been saying this probably over and over again over my career, but it is a very exciting time right now, because there are not only obviously all of the current therapeutic options with the extended half-life products and emicizumab, but a lot of the rebalancing therapies that, and certainly gene therapy on the horizon, that I think whether or not something like gene therapy obviously is entirely targeted towards, hemophilia at this point, but understanding the technology and how to use that to affect other conditions is also going to be important. So even if it's not the specific therapeutic agent, really the science behind these new developments are helping to expand the possibilities and treatments in all sorts of conditions. Obviously, bleeding disorders being the most important that we're talking about right now, but even beyond that. So it's going to be, I think there's going to be a lot that's going to come our way within the coagulation disorders community, and certainly we've already seen some of that.
Great. Two more questions that came in, and then everyone can resume their Irish step dancing and corned beef, or maybe Netflix binging with some Guinness, or red wine if you prefer that. What is the best resources for patients to learn more about subtypes of VWD?
Certainly, so the NHF website has a lot of great information. It's not just for hemophilia. There are discussion of all sorts of other rare bleeding disorders, as well as von Willebrand's on those sites. There is additional information that can also be found on some of your institutional websites, and so certainly there may be additional information found on those sites. I always tell families to be careful where you get your information. So if it's a place that's associated with a hospital or academic institution, or if it's an organization that is well regarded in the community, like NHF, you can be sure that that's good information you're getting. But do be careful with all the plethora of information out there, to choose those sites wisely.
Fantastic. And speaking of NHF, it's a great segue. Next week is Dr. Valentino, CEO of NHF. So please ask him that question. Ask him all the tough questions that maybe you waited to share. So the last question that came in is going back to Dr. Pels, your presentation, and it's about Hemlibra. Is there any evidence that Hemlibra can have a negative impact on bone density?
So not specifically I'm not aware of any data that Hemlibra itself can negatively impact bone density. And I hope I didn't misspeak, but the issue is that factor VIII, having actual circulating factor VIII within the system, may play more of a role in maintaining bone health. And so we're still learning and understanding that. And so it's a question that's been posed, and certainly for individuals with severe hemophilia who are no longer receiving factor VIII infusions, bone health is something that we'll continue to monitor closely, and make sure that we make every take the opportunity to ensure that individuals are not having any issues throughout their lifespan.
Thank you. Well, with that said, it's 8:34. I just want to thank this incredible panel for your time tonight, the amount of effort you put into this, for all of you for pivoting and believing in NEHA as we continue to provide that big pillar of education, which is part of our mission here. Before we sign off for the evening, I just want to go through our exhibit hall launches on Saturday. So you will hear a lot more. And there's a new feature, which gives us a little anxiety, but we're excited that after our presentation on Saturday, you'll be able to click all these booths and, just like you do in person, be able to actually Zoom video with our industry partners and not just chat. So that's something that is super new here, but there's a lot of information that if you want more information, you can click on all of these supporters and learn more about that there. And of course, go back to your providers. And we just want to say thank you. Thank you for your attention tonight, for your detail, for continuing to provide this. We really hope next March, this is always held in Bleeding Disorder Awareness Month, which is the month of March, that we will be in person. We still have the contract at the Rocky Hill Marriott in Connecticut. So Emily will be coming to your state, hopefully next March. We're working on a date there, but please come on Saturday. Saturday, it's gonna go by fast. As you know, it's from 9 to 11:30. There's 2 breakout sessions, psychosocial, where it processes the change. A social worker will be helping to address some of the things that we talked about today. And then insurance. We have a great panel about the roadblocks that insurance companies are put in some of the benefits of the manufacturer copay assistance. And we're going to have a discussion about that. Then we will break out into 20-minute breakout rooms, which is, if you've never done that, it's a lot of fun. You zoom around on Zoom. And then we will end with drawing our 2 round trip tickets on JetBlue. So thanks to a community member who works for JetBlue, 2 tickets were donated that could be used anytime this year to one of over 100 destinations. They're $20 each, and they all go to our emergency assistance fund. Sarah is going to put that in the chat. And we're really excited. This has already raised over $1,000 for emergency assistance, and it's been incredible to see the amount of support. And hopefully you can go on that vacation or maybe a little trip later this year when there is herd immunity. But with that said, thank you so much. Enjoy the rest of your St. Patrick's Day. Get your Zapal on Friday and wear your red. I'll be stalking you all. But with that said, have a great night. Sheila, leave us with some songs, Irish songs.
I don't know the words to that one. I just know the tune.
That was beautiful.
Bye-bye.
Happy
A
St. Patty's
non-Irish
Day,
blood is
everybody.
good.
Bye, everybody.
Thanks, guys.
Bye. Thank you so much.
Thanks.